Okay, Assalamualaikum. Sorry for the delay. I share my slide now.
Thank you, Dr. Hafizah. Sorry to interrupt you in your busy clinic.
It's okay.
Today we are fortunate to have Dr. Hafizah Zainuddin, our own UiTM Paediatric Respiratory and Sleep Physician. So Dr. Hafizah, this is our weekly sleep CME that we do every week
Right.
to discuss about sleep topic. Last week we have Prof. Said to talk about REM sleep behavior. This week we're going to have Dr. Hafizah to talk about OAC in pediatric patient, and next week going to have our own MLT, Mr. Helmi, to describe the present on the latest AASM criteria for titration and diagnostic sleep study. Okay. I think we can start now, Dr. Hafizah. Thank you. The floor is yours.
All right. Okay, my topic is supposed to be pediatric OSA, but pediatric OSA is actually a very big topic. To be honest, it won't be enough for just a few minutes talk on this. But I will just try to go through when actually we should be worried when we notice or we capture a children when they are snoring. So next is actually how common is actually snoring in children. So it's actually estimated around 8 to 10% of all children have this snoring issue. Different prevalence would have a different country because of our genetic influence, craniofacial structure, and therefore we have a different prevalence also among across different races. So among Chinese different, Malay different, and most common snoring affecting the American Negroes or black people. So this is actually because of more towards a craniofacial structure, even though they are lean and fit and healthy, but they do snores as well because of their genetic influence. So if you look, this is a quite old paper published in 2013 looking at snoring in children, and we are one of the country involved in this study, whereby they look into 14 countries, and Malaysia is more or less in between among which is also quite common having snoring or habitual snores among our children as well. So if we look back in our children, most of the time we don't really bother whether they are snores or not. That is the problem, and most parents thought it's actually normal to snores, as a father also snoring or the mother also snoring. But we need to be concerned and increase this awareness of snoring is not normal, and definitely is actually need some intervention to be done to see whether the patient already has some complication of that snoring itself. But which one is actually abnormal, which one is normal? Therefore, we only can know this by further history taking. So like I said, there's a lack of awareness. Children with a sleep disorder and snoring usually considered benign as long as tak ada demam, tak ada sesama, walaupun berdengkur, then they will thought this is actually acceptable for the norms. And medical personnel, usually doctors also taking sleep history very lightly, and most of the time not even taken into consideration to take this history of sleeping. And bear in mind, snoring is always a sign of upper airway obstruction, and chronic snoring is defined as snoring more than 4 nights per week. So if you have a child snores most of the nights, then you need to look back whether are you dealing with a complicated or more pathological snoring. So we go through a definition, because if it is just about snoring, when actually we need to worry actually, if it is something to do with upper airway obstruction, so which part of airway is actually problematic? Is there something that need to be done surgically, or is it can be intervened just a medical treatment, or we can just observe and see the children? So based on this definition, which is actually by ERS Task Force report. This is actually applicable for 2 years until 18 years old. The snoring itself, and if we look one by one, obstructive sleep disordered breathing mainly is a sleep disordered breathing. Is defined as a syndrome of upper airway dysfunction. When we talk about syndrome, it has to be with other symptoms as well, and also sign. So it's not only one thing. It's not only about snoring. So it will be characterized by snoring and or increased respiratory effort that result from increased upper airway resistance and pharyngeal collapsibility. So you will need to have all these component for you to define, or for you to decide whether your patient has a sleep disordered breathing or not. And what is actually the clinical entities means that from this sleep disorder breathing, we can have a range of symptoms, and when we can call this is just a primary snoring, when you have someone who actually snoring more than 3 nights per week without apnea, without hypopnea, but there is a frequent arousals from sleep, or gas exchange abnormality. So they don't have any other abnormality except for the snoring itself. So this is what we call as a primary snoring. So if the child came with a complaint of snoring more than 3 nights per week, but they don't have any apnea, they don't have any evidence of hypopnea, they don't have this frequent arousal from sleep or any gas exchange abnormality, you can put and categorize this patient under primary snoring. If it is someone with upper airway resistance syndrome, there will be a snoring, increased work of breathing, frequent arousals, but there is no recognizable obstructive events or gas exchange abnormality. So there is a snoring, increased work of breathing, frequent arousal, but no obstructive event. So when you do a sleep study in this patient, you will not able to recognize, or you did not get any good AHI to say this is actually significant obstructive event, and the gas exchange also should be normal. So this is what we call as upper airway resistance syndrome. And if you're talking about obstructive hypoventilation, there will be a snoring and abnormally elevated and respiratory carbon dioxide partial pressure in the absence of recognizable obstructive event. Maknanya patient is snoring, ada high CO2 level, but when you do a sleep study, there is no significant obstructive events that you can detect from the sleep study itself. So they did snores and they have a high CO2, but there's no obstructive event. So this is what we call as obstructive hypoventilation. And OSAS, I think it will be more striking to all of you, which recurrent events of partial or complete upper airway obstruction with evidence of hypopnea, obstructive or mixed apneas. And this is from the sleep study itself, with disruption of normal oxygenation, ventilation and sleep pattern. So it will be disturb your sleep structure as well. So this is actually definition from a ERS task force. Bear in mind this is for 2 years and until 18 years old. If you're talking about less than 2 years of age, it will be more complicated because of probably related to more towards a congenital abnormality or craniofacial structures problem that lead to this upper airway resistance. So common symptoms directly related to OSA we have just now about 8% of prevalence of children with snoring, but only 1 to 3% actually this child have a true OSA. So the most common one is adenoid and tonsils enlargement, and one of meta-analysis study shows that there is no association between tonsillar size and OSA severity. Maknanya kita tak boleh cakap lah semakin besar tonsil tu semakin teruk OSA dia. It doesn't apply in that way. So regardless what will be the size of the tonsil, you still cannot determine the OSA severity just based on the tonsillar size. You need to see other parameters as well, and also a sleep study as the gold standard of diagnosing of OSA. For screening tools, before we do or decide on a sleep study, we have a few actually screening tools for children, and the most established one is the PSQ and also OSA 18 questionnaire, which is more towards the quality of life. But you can get all this questionnaire in internet. But the thing is actually even doctors also doesn't know about this existence of the screening tools, and they don't really bother to use this questionnaire and ask a patient, even though patient comes with other problem, but the sleep history taking itself is actually very poor still among our medical personnel. So these are the tasks that I think we need to make sure that our doctors can do simple screening even with the history of snoring itself. And if needed, then probably you can use this PSQ or OSA 18 questionnaire to guide you whether are you dealing with a problematic patient or not. So patient in children, they can present with directly related symptoms like snoring, apnea, mouth breathing, abnormal sleep posture, parasomnia, or even excessive sweating at night. But they also can present with other related morbidity itself. They can present as enuresis. Maknanya datang like 8-year-olds, 9-year-olds still have primary enuresis or have elevated blood pressure as accidental finding when they do present with symptomatic high blood pressure, or even they have a school performance problem, whether inattention, cognitive deficits, academic difficulties, or even complaint from a teacher that the child actually has excessive daytime sleepiness. And the other thing is not only about obesity like in adult, I suppose in children, they can be a failure to try following this severe OSAS as well. So it can vary from direct related to the upper airway obstruction symptoms into the related morbidity or complication of the OSA itself. So sometimes patient came with other reason, and we noted that the patient has high blood pressure for the age, and doctor will investigate based on the hypertension, young hypertension workout, and forget about OSA actually. So that is actually the deficit of our awareness with regards of OSA in children itself. But I think with the exposures nowadays, more and more the cases are detected. Even our sleep study list also getting more and more, which is good in a way that our medical personnel now are aware of this problem. But in the other way, it's actually not good because of our developmental, children development is also affected with this OSA. So when actually we need to worry when the child actually snores, of course, if it is a young age group, less than 2 years of age, you need to be careful. Please refer accordingly to a pediatrician to see what is actually the problem of this patient when they present with snoring or even noisy breathing. And the other thing is about children with comorbidities. Children with comorbidities, we will discuss later a bit more on it. Common will be obesity and a history of prematurity because they have a risk to develop OSA. And those with a strong family history of sleep disorder breathing is also, like I said earlier, genetic influence play quite a role in this condition as well. So in a younger age group, if you're talking about less than 2 years of age, then we are concerned about more towards a congenital airway abnormality. For example, laryngomalacia or even a posterior laryngeal wall collapse. This is actually more like upper airway obstruction that can lead to a noisy breathing, and even the severe one, severe obstructive, and probably need to done some surgical intervention, and the worst scenario is actually a tracheostomy to secure the airway. And other genetic syndrome is also associated and presented in early age group, which they can present with early OSA symptoms. For example, Pirobine sequence and also achondroplasia. I think in adult also you have achondroplasia patient and they comes with OSA as well, but they can come as early as less than 2 years of age, when the achondroplasia is not that prominent at that time still, but still sometimes the obstructive symptom lead the diagnosis of achondroplasia the other way around. And don't forget about our neuromuscular disorder patient. This is more towards a congenital myopathies, a mitochondrial disorder, and even spinal muscular atrophy, usually SMA type 2. But now in type 1 SMA, we do provide the new drugs comes in with the new senescence and give a better prognosis, whereby from type 1 it can change to type 2. So the prognosis is better. But still, we need to anticipate that this person is among the risks who actually can develop a sleep disorder breathing and even can lead to OSA itself. Right. So children with comorbidities, the common one will be Down syndrome. So it's about 80%. Some papers actually quote even up to 80% prevalence of OSA in Down syndrome patient itself. And this is actually contributed because of multifactorial risks. One is the mid-facial and mandibular hypoplasia. One is narrow nasopharynx and short palate. They do present with adenotonsillar hypertrophy as well, with like other children, and with the generalized hypotonia in Down syndrome itself that lead to more towards severe obstruction. So the Maris et al. Published in 2016 in Down syndrome cohort itself, about half of them is actually towards a severe OSA rather than just a mild or moderate. So it's quite significant that you need to screen for OSA in Down syndrome children. The other syndrome is a Prader-Willi syndrome. This actually also a combination of risk factor to have upper airway obstruction, including the obesity, hypotonia, micrognathia, and also small nasopharynx area. And in a Prader-Willi syndrome itself, the prevalence even out can be to more than 50% up to 100%. So this also lead some impairment of the ventilatory control central apnea, means that they can present with the recurrent central apnea episode, not only obstructive but also central apnea. And with the new things, not really new, I think for the last 15 years, 20 years, we've been treating Prader-Willi syndrome with the growth hormone, and apparently the side effect is also quite devastating, and this actually can lead to the promotion of adenotonsillar hypertrophy and can cause a sudden death in this group of patients. So we are very careful in giving growth hormone in this group of patients, even though it's actually proven to be effective and good for the long-term outcome of the situation, but the obstructive event is actually need to be aware of, and this can lead to sudden death. So we need to weigh the benefits of the growth hormone for this group of patients. The other is cerebral palsy. I'm sure you all also quite familiar with the cerebral palsy patient. This is considered like a CP is something always pediatric. A common problem, they also have obstructive or sleep disorder breathing, and this can occur about 60% of them, and this following because of the abnormal muscle tone, hypotonia of certain upper airway muscles, and that lead to this obstructive event. And if we look at our patient nowadays, jarang-jarang lah, even pediatrician pun tak tanya sangat whether there's an obstructive event or not, or obstructive symptom or sleep disorder breathing in a cerebral palsy itself. They are more concentrating on neurological management, including the Botox, and to improve the contraction of the this muscle tone. But bear in mind, we also have problem when we diagnose this severe OSA in this patient, because of our limitation of our resources. There's not much of things that we can offer to this sort of patient, because if we want to offer a CPAP, then drooling of saliva and secretion issue is another problem to put this child on CPAP. And if we are talking about going for a surgical intervention, usually this is already like a poor prognosis if it is a severe CP, and we try not to give any more risk in terms of gases risk for this kind of patient. So it's a lot of need multidisciplinary discussion needed for this group of patients if they presented with severe OSA itself. So these are among other comorbidities, craniofacial abnormalities. Some children do have a problem with cranial synostosis, a small skull, early fusion of the skull that lead to this craniofacial structure abnormality and predispose them to snoring. So some of them have a midfacial hypoplasia. Usually this is actually more common among Chinese, midfacial hypoplasia, and the other will be a micrognathia severe one, like a pierobine yang teruk-teruk tu. You can see a very small chin and retrognathia as well, and this also can lead to some airway issues. And other comorbidities are skeletal abnormalities like your achondroplasia patient. Like I said, in adult also you do have all this abnormality, but usually what we want to do in children is actually detected this OSA symptom early rather than the complication itself. Other than that will be your MPS patient, mucopolysaccharidosis, and type 2 and type 4 is the one actually usually presented with severe OSA, and the other will be your connective tissue, your Ehlers-Danlos syndrome. Not that common, but things need to be look out and think about it if you see this kind of patient. So other will be obese patient. This is very, very common nowadays. I think for the last 25 years, I would say that the paradigm of our children growth is different. Last time when I was a medical student, more failure to thrive, malnutrition was seen in the ward. But nowadays we have a lot of obese patients rather than failure to thrive or malnutrition. We have this new paradigm issue, and a lot of factors actually associated with this change of health paradigm. And obesity is an important risk for OSA. This is by two mechanisms: pharyngeal fat tissue, which reduce the airway caliber and make it easily collapse, and also thoracic and abdominal fat reduce respiratory function, the mechanical function of the respiratory itself. And each increment in BMI more than 50th centile will increase about 10% risk of developing OSA. So that is another thing that we need to see and look at the progression of the obesity in our children. And there will be a residual OSA as well for those actually undergone adenotonsillectomy as the first line treatment for this if the adenoid and tonsil is enlarged, but they still can have a higher risk to develop a residual OSA. And of course, the weight loss will be a big challenge. It's not only in adult but also in children. And a lot of efforts has been made, and we also do have our limitation in the sense that like a bariatric surgery or weight loss surgical interventions and even a medication intervention is not well established in children itself. I mentioned this before about the risk of prematurity patient or cohort that lead to this OSA, and the more you follow up a patient with prematurity or history of prematurity, you need to identify whether the patient actually has this OSA, since that it actually proven that they have a high association with this group of patient. And those with the family history of sleep disorder breathing, usually mak ke ayah ke also snoring and also has adenotonsillar hypertrophy, probably the children, the offspring also would affected with the same problem. This is also proven and mentioned in the ERS Task Force report 2015. So how are we going to approach this patient? Number one, if you have a child at risk of sleep disorder breathing, we already discussed the definition, few clinical entity or category. And if you have these symptoms of upper airway obstruction and do the physical examination, try to look for any tonsillar hypertrophy, obesity, all the risks that we already discussed before, and we need to have some objective findings related to the sleep disorder breathing, whereby here we more towards overnight oximetry and also sleep study. This is actually from ERS task force, and they mentioned about lateral neck X-ray, flexible nasopharyngoscopy, cephalometry, and upper airway MRI or signed MRI of the upper airway. But I think in terms of our facilities, we don't really do all this except for the flexible nasopharyngoscopy, which is done by our colleague in ENT or even pediatric respiratory. Hypertrophy means that you detect that the patient actually has sleep disorder breathing, and you find out that the patient have a tonsillar hypertrophy, but the parents not keen for any surgical intervention or removal of the tonsillar hypertrophy, which can be the source or the cause of the obstructive event. So this child need to be followed up and see probably the OSA can get worse by time, and those with a craniofacial abnormality. So this is actually the objective diagnosis, how actually you're going to diagnose the OSA following the symptoms and the signs that you already detected earlier, and also the risk factor. And definitely, as I mentioned earlier, your level 1 PSG is the diagnostic gold standard diagnosis of OSA. And if you don't have this facility, you still can proceed with the nocturnal oximetry and do a screening tool with the PSQ, which is proven by a meta-analysis that is still worth to diagnose this patient and intervene early rather than wait for the PSG to be done, only then you want to do some intervention. So to reduce the complication, if you do not have that facility, you can just proceed with nocturnal oximetry, PSQ, and refer accordingly. So this is another algorithm, I suppose, how you're going to approach a child with this, but quite extensive investigation and intervention for this group of patients. And evaluation by respiratory and sleep physician is essential for high-risk children, especially those with comorbidities. If you have doubt, please just refer to pediatric, and pediatric will do the necessary investigation first before they can refer to respiratory physician, or if the hospital has this facility of respiratory physician, they can just directly refer to this person. With that, I thank you. This is all the reference. I open the floor for any questions.
Thank you, Dr. Hafizah, for the excellent presentation. So as Dr. Hafizah mentioned, I invite any question from the audience. Any question? Any question from the audience? Or ask Dr. Hafizah will ask question. In terms of doing sleep study for pediatric patient, how the children manage to have all the wires placed on their body? Dr. Hafizah, I just wonder about that.
Oh, okay. Usually, we don't have any problem putting the wire, provided that we introduce early. So you cannot put that wires when the patient actually sleeping. Bila dia terjaga, nanti dia akan rabut semua. So that one is really need some distraction and skills in terms of dealing with the young children. I think we usually put them on early, about 1 to 2 hours prior to the time of sleeping time, and then they will just get use of it. Some of them still cabut, but usually with the distraction, they should be bearable. And for those severe one, severe in the sense that yang sindromi, yang tak boleh tahan dengan benda stiker-stiker kat muka, then usually the sleep study will be aborted, or masa clerking untuk sleep study itself, masa kita decide and discuss with the parents on the sleep study, kita tunjuk demo what actually will be put on the patient's face, and then parents will decide lah whether anak dia boleh tahan ke tak. Kalau tak boleh, memang kita tak boleh buat lah. But most of the time, I would say that 90% of our children, even the younger age group, around 2-3 years old, also still bearable with the things, because there's no, tak ada cocok-cocok, hanya stiker je.
Okay. We have a question from Mawada. What is a reasonable clinical cut-off point for PSQ and OAC 18?
Oh, okay. There's no actually cut point. This is actually parents who actually answering the questionnaire. So depends on what actually the parents respond with regards of the symptoms of the patient. So there will be a scoring system actually, so which can give you an idea whether the patient actually have some sleep disorder breathing or not, based on what the parents answer. So it's not a cut point of age. It's not the patient who actually answered the questionnaire, it's the caretaker or the parents.
Of these two questionnaire, in your what in your experience, what is the best screening tool?
The best screening tool is a lot of modified one, but the well established is the PSQ.
Okay.
PSQ ada 22 questions, memang banyak. Tapi yang modify ada yang sampai 13, ada yang sampai 8 je questions. Some questions being dropped by the physician. So but still it's helpful despite all this modified screening.
The role of bariatric surgery in pediatric patient for OAC?
Sorry, pediatric surgery?
Bariatric surgery.
Oh, tak ada. Bariatric surgery tak ada. We did not offer that unless in adolescent group lah. Yang severe OSA, adolescent. That one also, that will be not the first choice, because most of the time we discuss the parents still a lot of patients following the bariatric surgery in young children. So kita tak ada evidence, and I would give this to the surgeon to answer probably more details. But in terms of our pediatric like in terms of option to offer this bariatric surgery will be a very quite tough discussion with the parents, because we don't want the complication post bariatric surgery.
Okay. Another question. For pediatric OAC patient, do they when they grow up, become adult, they still have OAC, or is already cured?
They can have recurrence of the adenoid enlargement. It is actually because of the adenoid enlargement. It depends on what actually the possible cause of the early OSA. If it is adenoid regrowth, then possible they can have residual or subsequent OSA following the regrowth of the adenoid. But if you're talking about craniofacial abnormality, yes, they can lead this to even in adulthood. But the only thing is actually when they are young, the airway is actually smaller. That's why the symptoms actually become more prominent. And when they get bigger, it's getting milder or asymptomatic. But if they're complicated with some obesity or any other problem with regards of the craniofacial itself, means that some part of the facial is not growing well because of some genetic abnormality, then probably they will have this problem even to the adulthood. I think most common will be those with the skeletal abnormality, craniofacial abnormality.
Dr. Hafizah, for adult patient, we have difficulty in terms of CPAP compliance. Do you have similar problem in pediatric patient, and how do you address this issue?
Yes, we do have a CPAP problem in terms of compliance, but you need to understand as well. Selalunya yang very bad compliance is a Down syndrome patient. Why? Because sometimes you need to see as well because of the tongue position. When they apply the CPAP, it's actually causing more obstruction when they're lying down. Because of this, that the thing actually, the CPAP doesn't really help and make it the symptom worse. So that is another issue. That's why in a Down syndrome, the approach is a bit different. We are more towards the surgical interventions like some supraglottoplasty and some glottopause PET-C being done for this group of patients because they cannot tolerate the CPAP. But for other children, because our mainstay treatment is still if they have a enlarged adenoid and tonsil, we go for the adenotonsillectomy as a first option. If they don't have this problem, I mean there's no adenotonsillar hypertrophy, then we look at the severity of the patient and try to look for what actually the possible cause of that OSA. If needed to be intervention, surgical intervention need to be done, probably you will do that first before you embark into a CPAP. CPAP kita reserve for those with the residual OSA lah. After all this intervention been done but still not working, or patient cannot tolerate or not keen for surgical intervention, then probably we put on a CPAP. But still, the compliance and also not even the compliance, but the getting the right headgear and mask is another issue in children.
Okay, Hafizah, another question. Do you practice asking parents to take video recordings of their children while sleeping to support history of OSA or snoring?
Yes, if they are not sure of that event, whether are you dealing with some choking episode at night, or is it is actually sometimes can be confused with seizure. So kalau dia confused, parents punya description tu tak classical like snoring, whether is it also associated with some epilepsy kind of nocturnal seizure. So kita akan suruh buat videotape lah. But anyway, it would not be as a screening tools per se, in the sense that based on the video you will decide when actually to do the sleep study. No, it still goes by other clinical symptoms.
Okay, another question. What is your opinion on unattended or partial PSD for PIDS sleep disorder breathing? Any
Okay.
particular cut of age, and in which can we rely on partial PSD for PIDS or adolescent with OSA? So, question depan.
Okay, if it is adolescent, probably still okay. But right, if you look at the sleep study, by 10 years of age and above, you should be able to treat this patient as like adult punya sleep study lah. So you can offer this level 3 or level 2 punya sleep study. But in a younger age group, kita tak advise. Even with the full sleep study, we have a lot of challenges and difficulty to get a right a good wave and what so not. So if it is a partial, sometimes you cannot just rely on that to interpret and diagnose the severity of the OSA. And furthermore, if you have someone with craniofacial abnormality or the cause of the obstruction itself, it is not straightforward like in adult obesity, then you also need to intervene in the sense that what else extra leads that you need to put in, or what would be the leads that you want to reduce or not to put in. So with that, I would say that adolescent without comorbidities, yes, you can proceed with the partial STB. Even meta-analysis showed that it's actually still reliable. But those with comorbidities, please do level 1 PSG lah.
Maybe I want to ask our ENT colleagues here. So in adults, in terms of surgery for OSA patient, we know OSA for adult is multi-level obstruction of the upper airways. For pediatric patient, how you decide which surgery is best to treat OSA? Do you do DICE similar to adult patient? Maybe our ENT colleagues from WADA or other ENT colleagues here can answer that question. Which type of surgery do you offer for PIDS patient, and how do you assess the suitability for surgery? From WADA? From WADA or Dr. Johannes? Dr. Rubin? Before that, Hafizah, after the surgery, do you repeat the sleep study for OSA PIDS patient?
We go by clinical first.
Okay.
If it's just a straightforward, and then we follow up the patient around 6 to 8 weeks post surgery. We see whether is there any residual symptoms of the patient, and if they do have a residual symptom, we proceed with the repeat PSG. But if clinically well, no more symptom after that, I will not wasted my sleep study punya list lah.
Okay. Sorry, our ENT colleague cannot.
Saya Farah. Formawadah boleh saya tolong ke?
Silakan.
Saya Farah daripada HUKM. Thank you Dr. Hafizah. Saya join melalui e-link daripada Prof Mawadah. For ENT side, kalau at our center, we do not, kita tak practice DICE, but we do adenotonsillectomy lah. Tu Prof Mawadah jawab. We do adenotonsillectomy, and if they have allergic rhinitis, which can, like Dr. Hafizah explained well tadi, dia boleh cause uncontrolled allergic rhinitis can cause a regrowth of the adenoid. We will do adenotonsillectomy and also stress to the parents that the nose symptoms needs to be treated, and compliance to medication is important lah. But yeah, agree dengan Dr. Hafizah yang kalau they have other comorbids, we will get feedback and also manage the case together with Paediatrics.
Thank you very much. So for Muadah, just answer. We also do laryngeo Malaysia, and we assess it by flexible scope and examination under anesthesia. That is answer from Muadah.
So usually this is actually for younger age group, for less than 2 years of age, whereby they presented with some obstructive symptoms, and we refer to our ENT colleague, and if there is evidence of laryngomalacia, probably they will do the scope and UA and proceed with the intervention if needed. And I would just comment a bit on DICE. It's not every hospital has the facility to do DICE, and we usually reserve this for those actually has a residual OSA, and we want to know which level of obstruction are we dealing with, and to plan the next surgical intervention. If it is just straightforward adenotonsillectomy, usually kita tak buat lah. I would not refer that to ENT yet until we find out there's some problem, or we suspect it's not just straightforward adenotonsillar hypertrophy, probably has some multi-level obstruction involved. Then we will discuss with our ENT team for the DICE.
Okay, thank you very much. I think we have a good discussion and excellent presentation by Dr. Hafizah. Thanks again, Dr. Hafizah, for the presentation. Thanks to the audience who participate in the discussion. I think we end our session today. Before that, I'm going to put for UiTM staff, you can claim your jam latihan. I'm going to put the link in the chat section. Okay, please do claim your jam latihan. Okay, the link is in the in-call message. Okay, thank you very much. Have a good day. Assalamualaikum warahmatullahi wabarakatuh.
Salam.